question about the US. So you interact with the full array of global healthcare leaders. How does the US rank in terms of healthcare?
There's a lot to learn from the US, and we in Germany, especially in Berlin, are trying hard to imitate a little bit this ecosystem approach, especially in Berlin where we are based, having the university hospital where we are based, Charité, working together with startups to create in creating better solutions. But it's obviously on a very different scale from that what we see in the US. So I think there US still excels, and there's a lot to learn for us and for other countries from that.
It's nice to hear. I'll share your praise with as many US audience listeners as possible. It's not every day that we get praise from a World Health Organization of any kind. So we'll take the praise. Okay, I'm joined today with Carsten Schicker. Am I pronouncing your surname correctly, Carsten?
Wonderful. Thank you. Yeah.
Good. Carsten, I'm honored to have Carsten on our podcast. He's the CEO of the World Health Summit. So I'd say probably the most global voice that we've had on the podcast to date, and hopefully a sign of things to come as we start to broaden out our horizons of interest to include other countries' approach to healthcare. So the World Health Summit that I'll refer to as WHS. Carsten, why don't we start by you maybe describing to our audience what does the World Health Summit do, and how does it fit into the larger global world health ecosystem? I'm thinking about organizations like the WHO, the EU, groups that we've all heard of. Where does the WHS fit into that?
Well, thank you, Roy, for having me.
Pleasure.
It's a pleasure to join you on this podcast, and happy to speak about the World Health Summit, which was actually founded in 2009. It started as a more or less academic conference. Scientists, researchers, mainly from Europe, came together and what they saw was basically a gap between the advancements we saw in medical research and science and what was actually happening all over the world. And they felt a strong responsibility to tackle that gap and to close that gap. So that was back in 2009. At that time, probably the term World Health Summit was a bit of hybris because it mainly brought together academics. That has changed quite significantly, and I think we are now the unique international platform for global health. What makes us unique is that we bring together stakeholders from politics, governments, science, the private sector, and civil society from all around the world. And what we want to do is we want to first set the agenda for a healthier future for all, and we want to catalyze and inspire innovative solutions for better health and well-being for all. That's what we do. So our main event is the World Health Summit each year in October in Berlin, but there are different formats, smaller events, sometimes even larger events we do throughout the year. We firmly believe that we can only achieve better health outcomes worldwide if all sectors really work together and start to learn from each other. In global health, it is obviously a highly political world, and it has become even more politicized in recent months or years, I should say. Global health or health is a political choice in the end, but if you really want to achieve good health outcomes, we believe all these sectors I mentioned need to work together, and we create the space for that to meet on eye level, discuss very openly the issues, find better solutions, and make them happen.
So Carsten, you were an incredibly effective executive within the media industry, Chief Strategy Officer at Bauer, SVP at Bertelsmann. These are two of the largest media houses across Europe and very much international. When you join the WHO and you take on such a global mission that is so broad, right? Healthcare is so huge. It touches so many different aspects of life, often intertwined with health as well and preventative care. Large topics like health equality, access to care, research and development, the latest and newest healthcare innovations. There's just so much to cover. How do you, using your executive experience, how do you measure success for the World Health Organization that you currently run?
Well, the World Health Summit, we do work together with the World Health Organization, but obviously we are a very separate institution.
Yeah. No, I don't mean the WHO. I mean the organization of the World Health Summit. It has an organizational mission. Forgive me for confusing the terminology, but
no worries.
For the business of World Health Summit, how do you measure success? Not necessarily in terms of number of events or number of attendees, but in terms of impact.
Exactly.
What do you keep an eye on?
There is a lot of things you can actually see that happen or that start at the World Health Summit. Just look at last year. In 2020, we hosted the largest event for the investment round for the World Health Organization, where $1 billion US dollars were pledged from member states and other institutions, philanthropies, for example, or even private sector players for the investment round of WHO. That was the largest event and the largest pledges WHO received so far, which was quite important for them also for their transformation journey they're going through. We have seen other pledging events. We have seen big announcements. We have seen the announcement to eradicate polio, for example. That happened at the World Health Summit. So these are obviously the highlight events, and you can in a way attribute the impact these events are having on the World Health Summit. But actually, I think what is even more important are the things that do not happen in the limelight of the big stage. We bring together 4,000 leaders from global health worldwide from all sectors. And what they do most of the time is actually network and sit together, discuss in smaller rounds, even starting from bilaterals to slightly larger rounds, creating trust, building trust among each other, really discussing the topics at hand and coming up with better solutions, new ideas. That's the impact we are also having. Obviously, that is harder to measure, but when we talk to our partners, to our attendees, this is the message we get very clearly. This is what the World Health Summit is really for: fostering, building, strengthening this network of professionals around the world and bringing them around one table. And that's not possible usually at other events. If you look at other global health events that are big and international, the World Health Assembly, for example, comes to mind, which is the, so to say, the General Assembly of the World Health Organization. But this is a very member states run, politics driven event. Each year in Geneva, you see thousands of people going there. But all the other sectors, not the politicians, but the private sector, the civil society, they are basically bystanders. They do a lot of side events, but it's very rare that people sit around one table and have a very open discussion. This only really happens at the World Health Summit in Berlin. And this is, I think, the probably immeasurable impact we are creating.
So in my mind, having not attended one of these events, I imagine in the best case scenario, different leaders from different nation states sitting around a table and sharing best practice, ways to reduce costs, improve quality, improve patient experience. And so you'll have health industry leaders and health department representatives, head of health in the UK, for example, sitting with the head of health in Namibia, Uganda, some unrelated country that wouldn't normally interact in dialogue with the head of health from the UK. And all of a sudden they're sharing experience in EMRs, digital data-based solutions, in analytics, in recruiting and retention, in training and education. And they're starting to go through one country's experience versus another and seeing if there's lessons learned that can be shared. Is that describing some of the value that's being created through this dialogue?
Absolutely. I think that this is quite accurate. If you follow the discussions around global health around the world, obviously there's often the perception that the global north needs to decide what's best for the global south, which obviously is not true. The global south is very diverse in the first place. So one solution that might work in one country in Africa does not necessarily work in another country in Asia. And there's obviously also the perception that health should not be decided in a place very far away from where people actually live. So what actually happens is in many ways that we see we can learn from each other. It's not that the global north needs to teach the global south how to do healthcare in a proper way. And if you look at our health systems, they are in one way or another all strained. It's not that we have the perfect example in any of the more developed countries that you can say this is the perfect blueprint how you do healthcare. We are very far from that. Actually, it's what I see is quite the contrary. We can actually learn a lot from resource constrained settings, how you can provide healthcare in a more efficient and more effective way, applying new technologies, for example. The one example that is often quoted is the one of Rwanda, which is a resource constrained country, rather small country in East Africa. What they have done after the genocide, they looked very closely at what kind of resources do we actually have. And it's pretty clear it's only people. So the government then said, there are two things we really need to focus on. And that is first, healthcare and then education. And that's what they do. And they really are innovators in many ways, and there's a lot we can learn from how things are done in Rwanda. And that's an experience I have when I travel around the world, that it's obviously always easier to build something from scratch than to change an existing system. But the openness and the trust in progress in new technology is often way more present and way more advanced in resource constrained settings than in our saturated Western societies. So I think there's a lot for us to learn from these countries in many areas. Not just the I would say the learning between countries. There's a lot again to learn across sectors. And I think we tend to look at healthcare mostly from a government's perspective. And it's obviously it's the government's job to make sure that healthcare is available for the people in a given country. But on the other hand, if you look at how healthcare is actually delivered, that is in many, many cases not always done by the government, but by private sector players. Doesn't have to be industry, but even a self-employed physician in a way is a private sector player. And I think we often should listen more to voices and lessons learned from the other sectors in order to create progress. And that's something we try to do, so that not only politicians talk with other politicians, but that they start to learn from private sector voices, from civil society, from philanthropies, and obviously from academics.
I think your role is so critical in our industry in particular, because I've sensed that, and I've seen time and time again in the US as an example, just one example, but in other countries too, that the idiosyncrasies of any one country's healthcare industry are so deep that we all get sucked into thinking about our country alone, and we stop comparing in detail and partnering with and sharing with lessons learned elsewhere. And then you also mentioned the north-south divide on top of that. So a lot of it is sort of bias that ultimately ends up hurting us. And I agree with you. These countries that are labor constrained or education and training constrained, whatever their resource setup is, might lead them to very different solutions for delivery of care. Right. And very different solutions for investment in drugs, investment in devices, investment in training. And those solutions might be really, really valuable to other countries who are taking a different approach. Not to mention healthcare just benefits from data, right? Examining more patient outcomes as opposed to less patient outcomes, more ways of creating structure and investment in different providers of care, right? Small practices versus large hospital systems versus aggregating groups that are national or international. There's just so much to examine. So you would think that the whole industry would follow your lead and everyone would spend a lot more time thinking about global health. But it does feel like global health for most is presumed to be an exercise in philanthropy, NGOs, foundations, and governments. And so everyone else is sort of excluded from the party. But it's just so refreshing to hear from you that there's heterogeneity out there, if I'm pronouncing it correctly. There's diversity. And that there's a lot of seats available to everyone to participate in the discussion. So I appreciate hearing it.
Absolutely. I think what you mentioned, just to give you one example, which made it very clear to me, we had a conversation with the Indonesian Minister of Health, who used to be a banker before his current role. And he told us when he looked at the whole healthcare system in Indonesia, the first thing he saw was that data was not interchanged between hospitals, physicians, and so on. And what he did is basically he said, I'm going to create a central data infrastructure. And that was, he told us in a setting with mostly Germans in the room. And everybody got a little bit nervous when they heard that they would store patient data centrally in Indonesia, and all the privacy red lights went on, especially in the German context where privacy is is a national treasure, I would say. But what he said was quite remarkable. He said, obviously, everybody and every patient has the right to opt out of that system and not have their data used in healthcare settings. But actually, no one really does it because people see the benefit when they visit a hospital that all their history, all the data is there and they can actually receive better care. So it's quite interesting that if you place someone with a different background in these roles, you often create new solutions that would have been ruled out in the first place due to concern that are very much inherited in the past, how you've done things. And I mean, to go back to your point, global health, yes, in the past 25 years or so, I think one thing stands out is we have created a lot of progress. Child mortality has been halved. We see strong vaccination rates among children. Obviously, there are still lots of problems to be solved, but we have seen real progress in many areas. Polio has been eradicated. I think what we're now seeing, and it's obviously a crisis in global health we are seeing right now, is because the funding cuts we are seeing are having an impact. I believe this crisis provides us with an opportunity to change and to change it for something that's even better than what we had before. And in the past, I think you put it rightly, investments in global health were often seen as charity and not as investment. And we didn't really have the mechanisms to make the investment also a worthwhile investment for the investor because we were lacking the data, we were lacking basically the capital market infrastructure, if you want. And that's something that, from my perspective, that needs to change the mindset. Health is not only a moral imperative, it is a strategic one. And we must approach health financing like we would any other big investment. And also, if we look at how we approach the problems we still have, we come from a world where we looked at them in a very verticalized way. We're going to eradicate polio. We're going to eradicate, or we want to eradicate malaria, measles, HIV, tuberculosis. And that's all good. I'm not arguing that we should not do that. But what we have failed in the past 25 years or so is creating resilient health systems all over the world that are able to adapt and to react to any crisis. And we all know a next pandemic will, and how do we deal with that? And I think there, in a way, we have failed. So that needs to change. We need to move from these very verticalized approaches, which we still need probably, but we need to complement them with more horizontal approaches.
Yeah,
And
I would agree with that.
Sorry.
I don't see how we get there without sharing information holistically, thoroughly amongst all the stakeholders. And I think you know it when you see it, right? When an industry is truly global, functioning based on best practice, you see it. You see the best brands emerge. Technology is a good example, highly competitive. And it's not like technology doesn't have partnerships with government entities. It does. It's not like it doesn't have significant regulatory constraints. It does. Typically needs more than it gets. But you see a vibrant, dynamic industry where information is flowing quickly and resources are being applied very quickly. Capital is being applied, winners, losers, and the end beneficiary is supposed to be us, the public. And I do think about healthcare in a different context, following a different paradigm. And it's almost like it's unsaid, but the term global health seems to be a brand that's associated historically with governments and philanthropic entities, right? Politicians, and to some extent, the desires of the elite class who really drive these philanthropic efforts and their individual ambitions. And so, yeah, governments are supposed to represent us from a democratic standpoint. They don't always do. But there's this other constituent, which is the capital class, right? Companies, entrepreneurs, founders, innovators, companies that are succeeding and scaling based on performance that generates demand, that generates more demand, that generates utility, and ultimately happy customers, happy patients. And I know that within healthcare, and I'm simplifying, we see that in certain segments, drugs and devices being a good example. Large international drug manufacturers, drug developers that have developed these global best-in-class brands, and very controversial space. They have good case studies and they have bad case studies. But healthcare delivery still remains very local, right? You don't think of a global hospital brand. These partnerships are emerging, but it still feels very much at the early stages. So, question to you: am I right in thinking about it in those terms? Do you think about it differently? And are you starting to see, maybe through your organization, maybe through the WHO, maybe through other organizations, the breaking down of those barriers, the introduction of global partnerships between different healthcare providers that are taking now full advantage of what different local markets have to offer in terms of expertise?
Yeah, we definitely see that happening more and more, because we just see the old model isn't working anymore, and that's not only due to the lack of funding we are seeing, but it's also in many ways I think we have reached a point where the marginal return is just getting too low for the programs we used to have. It's interesting because you said basically what we have seen is a scattered and very diverse landscape that is lacking common standards or common metrics around efficiency and so on. I think that's very much true for primary healthcare, maybe not so much for hospitals. That's already quite a competitive space in many countries, but for the vast majority of where healthcare is actually delivered, I think that's very true. On the
Yeah,
other
big
hand,
topics like access to care, training, coordination of care, right? Care treatment plans. It still feels like these are all questions. Who are we turning to for the right answers? So it feels like all that work is still ahead of us. It's very interesting. You mentioned the adoption of technology. We don't really have these for-profit brands that have risen and demonstrated that they're really the brands to back, the companies to back, to deliver to us the promise of best practice when it comes to all these big challenges. And so we're still relying on, and maybe incorrectly relying on, governments and nonprofit and foundations to solve these challenges. And I'm not sure that that's going to work. I'm not sure it's worked yet.
I must agree. What I'm a newcomer, still feel like a newcomer to the world of global health, and having spent most of my career in the corporate world, I find it stunning that there is so much skepticism around the good forces or the good ideas that can come from the private sector.
Corporate
There's
Yeah.
often the belief that only the government can fix that, only politicians know what's best for the patients, and I think that's wrong in many ways. It might be true if you think about public health, if you think about emergency response. I think there you need concerted government efforts. But I don't think that government could or should define every single aspect of how you need to run your operations in a way. Yes, we need regulation. We need to make sure that people have access to quality care and that you need licenses and all that. But I think you need to provide a regulatory framework, but then you can actually use the market forces in a good way and also in an equitable way. But there is still, if you talk to from governments, obviously, but also from civil society, there's a great reservation still that the private sector can have a good role in that, apart from obviously making profits. And I don't think that's something bad if you in the end also achieve good outcomes for patients. I mean, it's so in a
Agree.
way it feels like the world is still very much, the global health world is still very much paternalistic in a way. So even the philanthropies work very much in that way. We know what's best. We want to eradicate this disease, so this is what we do.
It's top down. It's not
very
bottom
much
up.
top down. It's absolutely not bottom up, and that's
The
something what
winners are
also
not emerging from the bottom up internationally.
Exactly.
They may be emerging locally. America is full of local winners, American healthcare companies. You speak to the average healthcare CEO of a winner of a $500 million revenue US healthcare company. They won't have a single opinion about a foreign market, not one foreign market. I mean, not even Canada or Mexico. It's too far. It's too remote. It's too different. It's so unique to healthcare. You would never find that in finance. You would never find that in retail. You would never find it in fashion. You can keep going down the industries. There's no such thing as I'm a $500 million revenue CEO and I have no interest in foreign markets. Healthcare, you find it every day. And it's fascinating. I raise the question to you. What about a country leader? So you're interacting with different countries around this topic of healthcare, what's working, what's not working every day. Have you settled around, or has the WHS settled around which model seems to be working the best from a national standpoint?
I think that is really the billion-dollar question, because as I said before, if you look at all the healthcare system, they all have their flaws. And right now, I'm unable to say this is the one system that works, because
I
I
mean, I
think
agree with you. I agree with you. And I think, by the way, I think we've only reached that point of understanding recently, where we appreciate that health outcomes and actual healthcare delivery are two very different things, right? You have to adjust for Japan's 5 to 6% obesity rate before you start comparing its health outcomes to 45% obesity rates in parts of the Middle East. They're just not the same in terms of what they have to deal with. And so it is interesting. It's a very complex topic, and we remain a little bit unsure of what we're trying to build, as long as that question remains unanswered.
Yeah, I do have a hypothesis how we need to approach that problem. I think we need to be both more holistic in looking at how we do that, and both separating the different parts of it more clearly. What do I mean by that? So I think we need to think beyond healthcare in terms of health outcomes. And a lot of health outcomes are actually defined by what you've done way before you became sick. So prevention obviously is the thing we need to focus on, with the burden of diseases from non-communicable diseases going up. And not only in the global north, but now also in the global south. We used to think about the global south, that is the home of infectious diseases, and the global north is the home of non-communicable diseases like diabetes, cardiovascular diseases, and so on. That's not true anymore. We see the same burden of disease, or similar burden of disease, in low resource settings, and we need to address them because the health systems are not equipped to deal with that. So we need to think a lot more about how do we make prevention actually happening, and also a worthwhile thing to invest into. That's one thing. And then I think if we think about actual healthcare, we need to separate more clearly the question: how do we fund healthcare? Who pays for that? And is it an insurance? Is it a tax regime? Many different models. But we need to separate then it more clearly from how do we deliver healthcare. And I think many of the problems we see in our healthcare systems is that the two things always get mixed. That we tend to think that we need to solve everything along the value chain, and then we have a very centralistic government funded model. Or we tend to think everything is going to be, the market will solve everything, and we see that's probably not true. At least not, you won't create equitable healthcare in the end. So I think we need to separate those more clearly and see what's actually working in terms of how you fund that, and what is working in terms of how you deliver that. And I fully agree with you. The delivery, the management capabilities in healthcare, if you look beyond hospitals, are really underdeveloped. And I find it striking. I'm a lawyer by training. I mean, what you see is law is actually something that starts on a very local level. And you would think that how can you actually internationalize, globalize that? But what you see is we have global law firms who are able to do that. And they do have the management capabilities to manage big firms that work around the globe. And as you said, I don't see anything like that in terms of actual healthcare. Yes, we have big pharma, but that's about creating a product and then selling it. But if you look at the healthcare delivery, I see a striking lack of good management also, which can be applied across the globe.
So much confusion, and the confusion doesn't seem to dissipate. I find it to be the industry with the biggest number of contradictions, that people speak out loud and they don't even hear themselves contradicting themselves. On the one hand, access to care, denial of treatment, a patient responsibility in terms of paying for care, these all are often stigmatized. When you talk about who pays for healthcare is still a huge topic in the US. And one of the themes here, where we have many different payers for healthcare, we have employers that pay for healthcare themselves directly. We have payers that pay for healthcare, what we call our health insurance industry, we call them payers. We have the government that pays for healthcare. We have individuals that pay for healthcare. We have local states that pay for healthcare. The list just goes on and on and on. And we still point fingers at any one of those solutions, especially if it's patients, right? One of the more recent podcasts I had was with the Kaiser Foundation journalist whose main focus has been over the last decade, patient balances, US patient balances, and how destructive they can be to an average family here in the US. So we're not settled here, and yet we have a lot of funding for US healthcare. We have over $5 trillion of annual spend on our own US healthcare. And so in the same token that we'll say, we are denying way too much care to people who have a right to receive care and shouldn't be overwhelmed with large patient balances. At the back end of that sentence, we'll say, and we have a massive healthcare spending issue. We spend way too much, more than every other country. And that's just one example of this contradiction where we both want to spend a lot, but we don't want to spend a lot, all mixed up with the same critique. And I see that in many different examples across healthcare. It's an industry that is very unforgiving. On the one hand, you sort of need many different solutions. You sort of need many different roles for different constituents to play if the system's going to have any chance of being effective. On the other hand, you get criticized for a system that's too complicated. No one understands it. Let's have a single payer. It's simple. We solve the problem of healthcare. We have one payer. Find me a country that has a single payer approach to healthcare, 100% government run, that is happy with the outcome, right? There aren't too many examples of that. But careful what you wish for when it comes to simplicity. Full of paradoxes, full of riddles and contradictions, this industry. That's right.
In the end, it's trade-offs, right? If you want to have that fully government centralized model, you basically kill competition and innovation.
Now that's putting a lot of pressure on your single payer to pay for everyone's health. They better be very wealthy. They better find a large oil reserve because someone's going to need to pay for all that healthcare.
Yeah. If you're Norway, that might work, but they have
Norway, it works beautifully. So let me ask you a question about the US. So you interact with the full array of global healthcare leaders. The US has been an example to other countries in other industries, not in all industries, but and by the way, every country offers an example to the rest of the world of at least one or two industries where it really champions itself, right? If it's automotive, what used to be Japan, now China, or if it's personal care, France, if it's high design, fashion, Italy, right? You keep going down the list. If it's German manufacturing, there's plenty of examples of countries that excel in certain areas. Agriculture, Israel, technology innovation. How does the US rank in terms of lessons to be learned, to be replicated, positive case studies in the eyes of foreign leaders? Or is it as maligned globally as it is domestically? And so the same question for all countries, right? Which country's approach to healthcare seems to be respected and maybe even revered more than others?
Obviously, I haven't done a study around that, so it's my own very personal, very biased view. If I look at
anecdotally
at where does the US excel in healthcare? I think the first thing that comes to mind is obviously academic excellence. The amount of research and also scientific innovation that is coming from the US is overwhelming and still strong. So, and I personally hope that this will continue even in the current political climate. What is also very strong is the translation of academic innovation away to actual commercial innovation. If you look at clusters like Boston, you have very, very strong ecosystems where academics, startups, more developed companies in the end work together to apply those new findings in actual patient settings and bring them to the market. I think that this is unparalleled how it's done. And I think also the quality you can actually get, especially in very complex healthcare settings in the US, is also unparalleled in the world. And at the same time, as you said, there are vast areas where people do not get the healthcare they should get, the need. So there's huge disparities. So it looks like the donut, right? In the middle, there is an area where basically you don't get a lot of healthcare. Then there's the donut itself where people get the right amount of healthcare. And then there's the area around where people actually get more than they need because it's commercially sensible to do so. But it's obviously if you look at it from a public good perspective, you're spending too much probably, which could have been reallocated elsewhere. So I think there is, in that sense, that there is the innovation, the quality, even the way and how things are done in an industrialized way and thus getting more efficient. There's there's a lot to learn from the US. And we in Germany, especially in Berlin, we are trying hard to imitate a little bit this ecosystem approach, especially in Berlin where we are based, having the university hospital where we are based, Charité, working together with startups to create in creating better solutions. But it's obviously on a very different scale from that what we see in the US. So I think there US still excels, and there's a lot to learn for us and for other countries from that.
It's nice to hear. So hopefully I'll share your praise with as many US audience listeners as possible. It's not every day that we get praise from a World Health Organization of any kind. So we'll take the praise. I do think it's interesting listening to the description of disparity in care across the US. It's very real, and it's something we spend a lot of time talking about. But what's driving it is something that I find particularly interesting. I recently spoke to the former head of CMMI, the CMS Innovation Lab, that was heavily responsible for driving Obamacare ACA's approach to value-based care in healthcare. Lots of models came out of CMMI. So this is Liz Fowler. And we went state by state using Kaiser Foundation data to compare what's going on across state lines. It is amazing how different healthcare is in America, depending on which state you're talking about. So it really is like 50 different countries in many respects. And what is striking is in certain states, the level of investment in Medicaid, which has really been over the past decade, 15 years since ACA, the primary resource or tool to address poor access to care for the lowest income class. And some states have significant investment in Medicaid and others don't. California, example of A, Texas, an example of B. It's also striking to see how consistently from one state to the next, it's not necessarily the availability of healthcare, it's connecting that availability to individual residents on a very basic level. I'll give you two good examples. Do you have a primary care doctor? Do you have a dentist? Or a few more examples. Have you seen your primary care physician within the last 6 to 12 months? And depending on which demographic you're talking about, once you get into Hispanics, especially more so than Blacks and African Americans, Hispanic access to care based on having a primary care physician is significantly orders of magnitude weaker than other demographics across the country, and particularly acute in certain states where you'll have 40, 50% of Hispanics that don't have a primary care doctor, that haven't seen a primary care doctor in over 12 months. And so we really have to start to sort of unpack these challenges based on what's going on in the field. And it is complicated. And I can tell you that the amount of times that I'm aware of state by state by state, and there's 50 states, right? That's a lot of work. Comparisons and getting into the cause and effect of these different outcomes is very complicated. And I'm not sure that we're spending enough time and effort really unpacking these challenges for ourselves, let alone comparing all of this globally. So it's fascinating. It's interesting. It's an industry that never runs out of interesting things to explore. But are we really solving for these challenges yet? I'm not sure.
It's very much what we also see, and if there are studies that just look at on the very micro level. If you look, for example, at life expectancy within cities, there are some cities where you can actually see life expectancy decreasing with every mile you go eastwards, and you would ask what's the reason, and going back to the 19th century, you would say those were all the factories and all the bad air that was coming out of them. But obviously that's not the case anymore. There are other factors. And I think in the global health community, we often take a too simplistic approach. We think we just need to pour more money into the system and the problems will get fixed. And that's clearly not the case, especially if you look at London. The example, I think, is based with the life expectancy. They have the National Health Service, and in theory, actually, everyone should receive the same level of treatment. But in essence, apparently they do not. And it has to do with access, which you described. It has to do also with information about healthcare.
Education, behavior.
Education,
yeah.
And that's a huge thing. I mean, we've seen it in the pandemic. The amount of misinformation, disinformation that has been spreading is so vast. So that's another battle or war even we need to fight. How do we make trusted health information available to every person on this planet to enable them to make informed decisions? When do I actually need to see a doctor? When do I need to see a specialist? When I need to see a primary healthcare worker? Just allowing people to make these decisions for themselves, and then obviously make sure that the financial means are there, that alone would provide so much value. So it's not only about the funding, it's always about funding, but it's not only about the funding, that there are many other things we need to do to really be able to provide equitable access to healthcare.
It's often a partnership. By the way, education typically falls into a similar paradigm. And the state that I'm from, New York, we always lead the tables in spend. Highest spender on education per capita, highest spender on healthcare per capita across the entire country, and very far from the best outcomes. And we don't really spend time to unpack that. So talk to me about COVID, not just the World Health and this organization, but many of our own institutions here in the US, the CDC, the FDA, when it comes to approving vaccines, when it comes to providing not just guidelines, but strict rules and regulations with consequences. When it comes to handling a pandemic crisis, I think a lot of the world has taken a step back from a presumption of expertise as a result of the experience of COVID. How do these institutions recover from that? I know there's been changes in leadership. I know there's a focus on transparency and maybe pushing forward in new directions. And I imagine that over time, these institutions will regain their footing. But you're leading one of these institutions. How do you think about the retrospective challenge of looking back at this experience, this 3-year experience that we all went through, and maybe coming back with a refined answer to the public to be able to somehow strengthen the partnership that these institutions do offer us and the role that they serve?
I think the biggest damage, besides the many millions lives that were lost and people still living with the consequences of long COVID and so on, that's the biggest impact the pandemic has had. But almost equally important is the erosion of trust we have seen. The trust within societies, the trust in science, the trust in institutions, that's a damage we have not yet recovered from. And I'm not sure how long it will take to recover from that, because I don't think we're already on a different track right now. I see a continuous erosion of trust in all these within societies and in institutions and in scientific research.
And I think, Carsten, that's also a really interesting statement to explore, continuing down this theme of local versus international. I would say 99% of the distrust that is experienced here in the US towards what happened in COVID is directed at our US institutions. It's the Dr. Fauci. Are you for him or are you against him? It's the vaccine development here in the US. Were we for it or against it? It's the CDC guidelines. And yet, I imagine that experience of growing distrust is replicated in a multitude of countries across the world, right? Australian citizens have their own experience with the Australian government. Right? Every country you could pick at had its own experience. So I think that lends itself to an interesting study, which, we often look at COVID, who did well, who did badly based on patient outcomes, right? Morbidity, mortality, who had the best per capita results, who had the worst. But I haven't necessarily seen a study based on trust. Which sovereign states maintain the highest level of trust with their citizenry as they went through the COVID experience? Any thoughts on that?
I would love to see that study. I know there are some studies that actually measure trust, but obviously there are always some dimensions they miss on. What I want to add to that, it's not only with the trust within society, within countries, it's also the trust between countries that has suffered a lot. Because in the end, and we had our regional meeting back in 2022 in Uganda, and it was so I wasn't there, but what my colleagues reported from that was such a huge disappointment and even anger in how the global North basically treated the global South in this pandemic. And because it was contrary to everything that had been said before that. So there was no solidarity, there was no friendship, there was no sharing of research, there was the whole discussion about who gets the vaccines first. That was obviously something that really deteriorated the relationships between many countries. And I think this is what we are seeing. This is why we are now facing a crisis of the multilateral system, because even countries don't trust each other anymore. And it took us years to reach a pandemic agreement. Only this May took way longer than we all anticipated. We thought the pandemic was here. We so many lessons learned. We know how to do it better. Let's get this agreement fixed. No, it took us many years. And actually, yes, there was a big achievement now in May that this pandemic agreement was reached. But the devil is still in the detail. How do you do the pathogen benefit and access sharing? All the details are still a bit unsolved. But this is really where the essence is, and where you see that trust isn't there yet. That you would actually, if you share information about pathogens, that you would also receive the benefits. That's why the discussions took so long. And this is why we have the crisis of this multilateral system. For me, it's all in the end the consequence of the pandemic, because we lost trust in every direction, even on the very small level within communities, even within families, and goes on the global scale that we lost trust between countries. And so we work hard to re-establish that trust, and we believe this trust can only re-established on the very individual human level. If you trust your counterpart, then you might trust other people, but you need to work on that level again. That will take many years to rebuild that trust.
It is fascinating that the pandemic taught us the importance of coordination and shared data and transparent dialogue, and yet we have less of it as a result, because we didn't really rise to the occasion in the eyes of a lot of our peers. This global pandemic agreement, tell me a little bit more about it. In the best case scenario, let's assume you get through the details. What does it solve for that we didn't have?
The pandemic agreement is very much how do we act and how do we prepare for these emergencies? So how do we make sure that we actually have those resilient health systems in place, that we have trained workforce that is able to deal with these pandemics? So it's a lot about is prevention and preparedness. And then it's obviously also about the response. How do we work with the pandemic once it's there? How do we develop vaccines? How do the pathogen access and benefit sharing? That's one of the most highly debated things in that thing, because what happens is you have the disease might start in a country, but that country might not have the resources to analyze the pathogen, might not have the labs, might not have the pharmaceutical complex that's able to start producing vaccines. That's a global thing. So how do we actually make sure that the country who has this pathogen and sends it over to a lab in the global north, so to say, actually then gets also the benefits of sharing that information, benefit in terms of testing, how can we actually test for that pathogen, how we can even assess the size of the problem, how do we get access then to medication, to vaccines and all that needs to be regulated. So it's about all these different parts: preparedness, prevention, preparedness, and response. And there are many things that need to be done, and where we still need global coordination. Because one thing that is clear and has been clear all the time, and you can't change that, a pandemic or certain diseases don't respect borders. You can do a lot about border control, but you will never be able to stop a highly pathogenic infection, for example, in crossing a border and creating havoc.
I think that was
absolutely not possible.
That was a really important lesson that we learned from COVID. I had my own model that I was running very early on. And based on the frequency of infection, the conclusion I reached in summation was, oh, this thing is traveling at the speed of light. Good luck trying to slow it down. And it took us, I think, about 2 years to realize that, I don't know, 500 million infections later, we weren't slowing anything down. And I think that's a very human condition, especially by institutional leaders, heads of institutions, to think that they have all the power in the world to deal with anything, and that the expectation is that they can and will deal with anything. And some things we don't have the science to overcome yet. And a highly infectious disease is highly infectious. And it's sort of coming to terms with that seemed to be a struggle. I'll ask you another question in this regard. If I was in the room with this global pandemic agreement, I would ask for a way to solve the race to the bottom. And what I noticed very quickly, what a lot of us noticed to our dismay, was that it seemed like our response to the disease, the virus, was by whichever country was responding most aggressively at that point in time. So if there was a country that was forcing quarantine, forcing home confinement, forcing the shutting down of schools, forcing, prevention of social interaction, forcing the shutting down of religious institutions. The list just goes on and on and on. I mean, there was hundreds of things that were mandated from one country to the next. And it felt like what was driving that was whichever government was demonstrating that it was the most safe, the most risk averse. And so all of our leaders seem to coalesce around how can I maximize safety in this time of mass risk and mass pandemic and mass insecurity and fear. And I get it. I think that's a very human reaction from everyone. But I'm not sure it's the most logical or rational to do that, because what you end up with is one policy solution that everyone follows. And what if that one solution ends up being horribly ineffective and net negative? Whereas if we had 100 different countries responding in 100 different ways, maybe we would find an example of a response that, based on merit and based on performance, ends up proving itself like a market approach to be far more intelligent. We didn't do that. It felt very homogeneous almost immediately. China, let's do what they're doing. Then we went to Italy. Italy saw that they had no control over this. It was total panic and chaos. Complete military operation, total shutdown of the country, as rigid as arresting people who ignored curfews, you name it. Let's go do what they're doing. And it just sort of not only did the virus travel across the world at the speed of light, regulatory policy traveled around the world at the speed of light. And whereas you would think that maybe we slow down and ask more questions, and social media notoriously played its role in this too. Shut down discussions. So all the science, right? So many scientists who are trained in critical thinking, a lot of that was muted because we're in and that's a scary idea, because if we haven't solved for that, why wouldn't we do exactly the same thing the next time?
Maybe two thoughts. First, the pandemic agreement we spoke about does not address that. It basically does not take sovereignty away from the countries, how they actually react to a pandemic. And I think that's a good thing, because it obviously does, for many reasons, doesn't make sense for an institution like WHO to decide what needs to be done in each and every setting. They're just not equipped for that. For many reasons, it just does not make sense, and it's not in this pandemic agreement. That's actually something that is attributed to it by people who don't like it, but it's simply not true. The country's sovereignty is still intact, and they are empowered actually to act. The second thought is, I think, and that's the interesting question: what do you actually measure? So, what is success in dealing with the pandemic? And I think we, at least in Germany, we spent too little time discussing that question. And in the first place, it was about avoiding death and then avoiding infections. Yes, those are two indicators, and it makes a lot of sense in terms of health outcomes. But we did not discuss as much about mental health outcomes. If you lock people down, what happens to them? If you do not allow children to go to school, to kindergarten, what happens with them? We are only having discussion. Preventing care. So all these other effects were not in focus, and we not saying that there is a simple answer to that, but we need to have that discussion. I understand that you can't have that discussion at the height of the pandemic or when you need to react fast. Then you need to think of what's important. Okay, it's about saving lives first. But then over 2 years or 3 years or now, we must have that discussion learn for the next pandemic. What do we prioritize in which setting? And it was in COVID, it was after a couple of months, it was pretty clear if you look at children that they were not as much affected by this disease as adults. So why do we still had schools closed and all that? So, and that discussion still in many ways needs to happen. We haven't gone through that in the full depth of it. And I'm afraid that we will not have that discussion, or at least an aligned approach, how we have that discussion then when the next pandemic is going to hit us.
I think and we'll end there because I want to be sensitive to your time, even though we have so much more to cover. We haven't even touched AI and technology. But I think, Carsten, you have all the answers you need for the next pandemic right in that sentence. If our elected leaders, and in some cases unelected, aren't having an open dialogue with us as members of society about the next pandemic now, If they're not talking about something as simple as, in the next pandemic, please anticipate that there may be a scenario where some of you are forced to quarantine because of your age group, because of your gender, because of your ethnicity, whatever the reason is. And others might not, because, hey, we're in a society where we need to function and other needs are also going to remain important in the middle of a pandemic. If our leaders aren't reminding us of that on a regular basis as part of the everyday reality of being an adult citizen, they're not preparing themselves and us for the next pandemic, because it's going to be, if we're forcing the child to stay at home, we better force a 75-year-old too, otherwise there's inequity. What are the priorities in the middle of a pandemic? Is it feel-good social equity, or is it let's maintain trust in our institutions because they're going to use science and common sense to try to maximize value, utility, goodwill, and outcome as we go through it? What are our goals? So I think, Carsten, that you're really nailing the question and the issue, and I'm so glad that someone like you is sitting in a seat where the World Health Summit is able to bring these topics into discussion and at least engage in debate.
Thank you so much for having me.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.